how is each of them transmitted, what signs and symptoms might somebody having the disease present with, and then how it is diagnosed and some complications, and then a bit of treatment and prevention, and then a bit of a health awareness message at the end of the presentation. Bida, do we have the poll questions?
Not really. We do not have.
Okay, if we don't have that, then we will proceed with the discussions. Otherwise, yeah, so we will skip that. Now, let's begin with the malaria. The term malaria, or the name malaria, by origin, it's said to have come from two Italian words, which are there: mal, which means bad, and then aria, which actually means air. So malaria is more of bad air. That's just a bit of history to the name malaria. I realized I had not put my video on, sorry. Yeah, so malaria is caused by a parasite, and the parasite is called Plasmodium parasite. There are many species of this parasite, but mostly 4 of them are common. And especially in Africa, you can find most of these 4 species, which are the falciparum, the vivax, the malaria, and then ovale. Now, the falciparum is the most dangerous species of the Plasmodium parasite, and it is also the most common cause of malaria. Most of the malaria, especially in the tropical regions, is caused by this particular species of the parasite. It is spread, the Plasmodium parasite is spread by the female Anopheles mosquito. So the female Anopheles mosquito mostly feeds on blood because of reproduction purposes and reasons. So when it carries a parasite from its saliva, and then it sucks blood from a human being who doesn't have the parasite, it tends to transmit the parasite in that process of sucking blood. Other possible ways of transmitting malaria include blood transfusion. For example, a blood that has the Plasmodium parasite transfused into somebody who doesn't have the parasite, that person can get the parasite as well. Organ transplantation, such as liver transplantation. As this presentation will not go into details of that, but the way the life cycle of this Plasmodium parasite is that there are certain stages when the parasite actually grows in the liver. So if part of such liver is transplanted when the parasite is there, that can also be a cause of transmission. But maybe for us to know of importance is also that Plasmodium parasite can be transmitted through the placenta, meaning during pregnancy from the mother to the baby. Okay. As I mentioned, there are stages of the life cycle of the parasite that occur inside the human body, both in the blood and inside liver cells. And then the reproductive stages really happen in the salivary glands of the mosquito. So for the parasite to exist, it needs the 2 hosts, the human being for the different stages that exist, and then the mosquito for the other stages. Now, there's something we call incubation period. This is the period between the moment somebody is infected with the parasite until the time symptoms or signs begin to appear. The different species of the parasite have different incubation period, like duration in days. Of course, as you see here, that falciparum is having the shortest duration, about 9 to 14 days. So a mosquito bites me today and injects the parasite in me, within 9 to 14 days, I am likely to begin showing signs and symptoms of malaria if it is the falciparum species. And this is for the other species. Another important thing to note is that for these different species, there's a bit of characteristic way the malaria presents. For example, for the falciparum, it can present in a very severe form and quick to come on. The symptoms and signs are quick to come on, a sudden onset. That's what we call fulminant. And then its fever can come and go. So it just recurs between 1.5 days to 2 days. So it can come today, maybe it will subside another 36 to 48 hours later, it will come back. So that is typically a falciparum kind of malaria. The other two species, vivax and ovale, their spikes of fever are about every 48 hours, and they tend to only also have what we call the latent stages in the liver. And that's what I said in the previous slide, that can cause transmission through liver transplantation, because some of their developmental stages can remain in the liver latent. So they are dormant, but they can be activated anytime and can cause malaria. The fourth one, the malaria, it takes about 18 to 40 days as incubation. So it's longer. Somebody can be bitten today by the mosquito and still get these signs maybe a month later. Its fever will be every 3 days. It comes and may subside and then come back about 3 days. So that's what is characteristic. This information may be helpful for a medical practitioner, for example. Now, to understand the burden of malaria, you see this world map here, and you see a lot of red, especially where we are. So all these regions marked red, as you see in the key, these are areas where malaria transmission often occurs, and it occurs a lot. You will see that these are the tropics, around the tropical areas of the world. So malaria is so common there, as opposed to the yellow zones where these are areas in which malaria has basically disappeared and has been eradicated or even never existed before. Most of North America, and then parts of Southern America, and then Australia, and so on. Now, in 2022, the WHO released what they call the World Malaria Report. Now, that report explained about malaria cases by the end of 2021. For example, 247 million cases were diagnosed in 2021, and 619,000 of those actually died of malaria. That is worldwide data. Okay. In Africa, out of 247 million across the world, 234 million, that's 95% cases actually happened in these parts of Africa here. Okay. So we contribute 95% cases of malaria in the world, right? With 593,000 deaths. This is 96% of the total deaths in the world from Africa, okay? And then of this number, actually 80% of them were children of 5 years or less, okay? So we see that malaria kills a lot more under 5 children. South Sudan per se, according to WHO, accounted for 1.2% of these cases, and also another 1.2% of the death cases. They concluded by saying in South Sudan, at least 20 people die of malaria every day. So today, Saturday, by the end of today, about 20 people should have died of malaria across the country. You can do the math to know by the end of the year how many would have really died. Okay. Common signs and symptoms of malaria include fever. Most people who are infected with the plasmodium will show up with the fever, chills, headache, muscle pain, and then you begin to get lesser signs and symptoms, such as liver that is enlarged and can be felt from outside the body using your fingers, okay? Or even the spleen as well can enlarge. Somebody can get the feeling to vomit, or actually they will vomit, and then there might be also pain in the abdomen and even sometimes diarrhea. Okay. These signs and symptoms, as already explained, tend to happen in cycles. So they come and go, especially for the fever. Signs and symptoms of malaria have been classified broadly into 3 stages. So from the end of incubation period, when signs begin, usually it is the cold stage. Somebody is just feeling chills and shivering, even when the sun heat is so hot as it is in Juba, for those who are in Juba now. So even when the sun is that hot, somebody is having chills, they are shivering. That is what we call the cold stage, and it may go. After that, it is replaced by what we call the hot stage. And in the hot stage, somebody gets the fevers now. They can also get headache, which will now be followed by sweating stage. And if the sweating is so much, so profuse, somebody often can get weak, because of loss of body fluid through the sweat. So this is basically a description of how the signs and symptoms of malaria often show up. In trying to understand whether those signs and symptoms are for malaria or another thing, because most of them can also be found from other infections, can also be signs and symptoms of other infections, for example. So if a patient goes to maybe the clinic or to see their doctor, of course, those who are medical personnel in this call, you know what it means to take history of the illness. You want to ask about maybe travel, especially if you are in a country that has no or little malaria prevalence. Of course, in South Sudan, you don't need to ask somebody if you have traveled from maybe Juba to Rank or to where. We know South Sudan is one of the countries with the endemic malaria cases. So travel history may not be helpful here, but for other nationalities, you might want to know if they have ever traveled to a country where malaria is so prevalent. And then, of course, you begin to ask about the characteristics of the signs, the symptoms, and the fever, how it behaves, and things like that. Okay. After taking your history, of course, usually is physical examinations, beginning with the basic things. You can check the temperature using the thermometer. You can also do other things that I will not go into details here because this is not really meant for medical personnel. But yes, physical examination can help you, including also identifying enlarged liver or enlarged spleen. So all that is part of physical examinations. Of course, at the end, it will be tied up using laboratory tests. They can take a blood sample from the patient, and that is the most preferred way to test for malaria, where they make what we call a blood slide, and then they look for the parasite itself in the blood. They look for it under the microscope. That is the gold standard, because there's a way the laboratory personnel will be able to identify that what I'm seeing here or there are actually malaria parasites, and then they will report. Sometimes they report it as plus or 2 pluses or 3 pluses. Any malaria that is reported by a well-trained or experienced laboratory technician as 2 pluses or 3 is considered severe, at least by the way the testing is done, the microscopy. There are other test kits that we call them rapid test kits that can also be used for screening for malaria. But the problem with those kits is that when it is an early presentation, like parasites are still not so many in the blood, the test might come out negative. Okay, that's why it's preferred that really looking for the parasite is the best way to diagnose. If somebody presents with those symptoms and signs, and I am your doctor or clinician seeing you, I would also be interested to know other things, because there are other diseases that might also present with the same characteristics. So I will probably have to ask you to give, or rather to do a blood count, what we call complete blood count. In this, I will be able to see many things, including amount of red blood cell in your blood and so on. They can also tell me about if it is already a severe malaria or not, okay? And other tests, including sugar levels in the blood, can also be helpful. The PCR test is not for clinic laboratory, it's for national laboratories that want to do studies on malaria parasites, for example. Okay. Malaria can be as simple as a fever and a headache, and you walk into a clinic and then you get your treatment and you recover. Most times between 48 to 72 hours, somebody is good to go. That is called uncomplicated malaria, okay? But sometimes when, for one reason or another, attention is not given early, or the parasite amount is so much at a time, it can lead to complications. And then we call that complicated malaria. And sometimes we also refer to it as severe malaria. Complicated malaria now has many more other things that can be found in the body of the patient, other than just the fever or maybe the headache and the other signs and symptoms we saw. For example, if you do the CBC and you find very low red blood cells, which medically is termed as anemia, that can be a result of complication of malaria, because as the parasites multiply inside the red cell, they become many in numbers and the red cell can burst. Okay. And then when it bursts, those parasites have to find and also grow in other red cells. So that continuous bursting and breakage of red cells leads to what we call anemia. So that is now a complicated malaria or severe malaria, and it depends on the amount of red cells. Somebody might need to be given blood transfusion, or they can be managed with the other medications that will help with the more blood being produced. Another complication can be cerebral malaria. So when the malaria goes into the brain and injures the brain, it can present in many ways, including, for example, decreased or even loss of consciousness, and then convulsions and other presentations that are typical of cerebral diseases or brain diseases. So that can also be confusing picture for some people, you know, to tell what is causing this. It's not necessarily maybe demons or things like that, but it could be just malaria parasites causing that kind of presentation. Organ enlargement, as I said already, so these two organs, mainly the spleen and the liver, of course, can enlarge as severity of the malaria increases. Like for the liver, I said some of the parasites can actually stay in the liver and lodge there and keep growing in there in numbers. Kidney failure can come from many reasons, including, of course, little red blood cell. So anemia can come from maybe the sweating, the vomiting, the diarrhea, so little fluid in the body. All these can over time result in failure of the kidneys. Also, it can result in difficulty to breathe due to effects on the lungs, okay, what is called as acute respiratory distress syndrome. Sometimes when the malaria also is now so severe, and because of loss of body fluid, sometimes there can be accumulation of fluid in the lungs or even in the brain. So that accumulation there actually reduces the circulating fluid now because it becomes confined in those body parts. It can result in shock, jaundice, which is yellowing of the eyes. And for pregnant mothers, especially if it is the P. falciparum species, actually it is worse because it can cause preterm birth, that is at best, but at worst, it can actually cause a miscarriage. So you will see that malaria is not just a very simple thing, as some people might want to think. It can really complicate and become very, very bad. So those are some serious complications of malaria we should know. These two pictures on the left here is showing a child who is probably convulsing. This might be cerebral malaria or malaria that has gone to the brain. And this is maybe a clinical or clinician trying to look out for paleness of the lips, which is a sign of anemia or a sign of low red blood cell. So could be checked in the lips, they could check in the eyes, or even in the palms of the hand and even the soles of the feet. So all those are places we can look out for signs that, oh, malaria is severe because there's less red blood cell in the blood, in the body. Treatment for malaria is both supportive and also definitive. Supportive means if I have fever or headache, I should be given something like maybe paracetamol, Panadol, or whatever you want to call it, different brand names, to help with that. Sometimes tepid sponging with lukewarm water, not hot water, again, not cold water, may help with the reducing the fever, okay, may help with reducing the fever, but paracetamol or any of these fever or pain relieving medications can be helpful to treat that. But if it is diagnosed, tested and found to be malaria, then you now need the actual treatment for the parasites. And the preferred is what we call the artemisinin combination therapy, or ACTs. many brands in town. You hear of Coatem, you hear of Lumatem, you hear of Lonart, you hear of what? Most of those anti-malarial drugs are actually what we call the ACTs. So mostly they have artemether, they have lumefantrine in it, and then you get the others which have amodiaquine and artesunate. All those are currently medications that are available, but they have to be prescribed by a trained personnel in terms of how many tablets, for example, one needs to take and maybe how often. In some cases, for example, in pregnant women, quinine is the best or preferred drug for treating malaria, unless maybe it is not there or other factors, then the ACTs may be used. Fansidar, which is also a common brand name around, sometimes is also used for preventing malaria during pregnancy, but in some cases it is used for treating as well. Chloroquine, very old medication, most of us might already have known as a treatment for malaria. There are others which are also treatment for parasites such as atovaquone and so on. If a patient has complicated malaria, for example, low blood cells, red blood cells, as I said, and there is a possibility, then they can be transfused. Okay. Of course, giving fluids is helpful because they are either sweating or vomiting or diarrheating a lot. So you want to give them more fluid. If they can drink, assuming they are not vomiting, maybe they drink a lot, or IV or rather drip water. So it's also a helpful way to just maintain the body balance. Okay, now if malaria is diagnosed as severe or complicated, most times we begin with the injections. And then after maybe 24 hours to maybe 36 or 48 hours of injections, depending on the improvement seen, they will then be shifted to complete a 3-day course of what? Of these oral medications. So that is how malaria treatment should really be. But of course, we have most times, sorry to say, but it's a reality that most times women tend to not like tablets. So they will want injection, even when it is not a complicated malaria and somebody could just walk home with the tablets and then 3 days later they are fine. So these are some difficulties medical personnel face, but the requirement is if it is not complicated, then take the tablets, take oral treatment. If it is severe or complicated, then the personnel, the clinical personnel should be able to prescribe the injections. It should not be because I like this treatment or I don't like the other, right? Now, how do we prevent malaria? So I like this picture, that's why I included it here. It seems to simplify prevention of malaria. Sometimes we take it for granted what it is really about, but you will see here, these 3 people are trying to chase out mosquitoes, I don't know, through the window or something. You know, they're trying to just use their hands to chase out mosquitoes and whatever that is. Maybe looks like something like this tennis, what do they call it, for playing tennis. So they are just beating around the mosquitoes and the mosquitoes are all over. As opposed to what this person here is doing, you know, looks more scientific, seems to have things that tend to chase out mosquitoes. So you can compare the 2 pictures and see which one can give you success in preventing malaria. But I also like this picture more because of the ABCD against malaria. So awareness, which is what we are doing now, helping you recognize that, oh, I might be having malaria, okay? Or awareness in terms of I am in a malaria endemic place, so I must practice malaria prevention measures. That is all awareness. Oh, I feel like this, I need to go to this clinic or that clinic to meet somebody like this, or even that facility, health facility. All that is awareness. And this session is part of helping us with the A. Preventing bites, which is the B, bite prevention. So it could be using many things, as we shall see in the next slides below. Okay, we can use many things that can help us to prevent bites. Of course, here we see a mosquito net put just above the bed or rather on top of the bed. So that can be very helpful to prevent bites. Chemoprophylaxis, this is now basically the drugs, the different drugs which can be used for either preventing malaria or even what. Yeah, these are basically for preventing malaria. We will see some of them in the next slides. And then the D is diagnosis. It doesn't end with the diagnosis, it has to also follow with treatment. So being diagnosed to have malaria and diagnosis is done early enough and then treatment started in time, that also in other ways helps prevent transmission, because then the malaria parasite would have ended with me who is diagnosed and treated. Okay. So if you remove the A, which is awareness, you will really think of 3 ways here. Attack parasite in the body. Attacking parasite in the body is the diagnosis and the treatment itself. Okay. And then reducing contact between humans and mosquitoes or the parasite itself. Okay. So that is more of the bite prevention B. So we mentioned things like repellents. The repellents could be lotion that you smear on your body, mostly on the arms and the hands and the feet, areas that are exposed to mosquito bites mostly. There's also a very common thing around, you see boys carrying, where they see people are congregating, they carry around mosquito coils. Mosquito coil is also another repellent that can keep away mosquitoes, at least for the time you are not in your mosquito net. You can have one of these used and then mosquitoes will not bite you. Of course, using the mosquito net, which is mostly the insecticide treated nets, these are very helpful, more specifically for pregnant mothers, under 5 children. All of us really need to sleep under a mosquito net anyway. But of course, I know sometimes the weather is not friendly. Other people say they are not comfortable sleeping under the mosquito net. And you see that these are some challenges that keep us, battling malaria every year, because people are not keeping themselves away from the parasite so that the parasite actually disappears, Using preventive antimalarials. So that is the C, doxycycline, mefloquine, and so on. I will not talk into details of this because these are mostly used by people who are naturally living in areas without malaria, who want to travel to, for example, Africa or the tropical parts of the world where malaria is prevalent. They may take these antimalarials in time. Some of them can take 1 month before, others a few weeks before they travel, and then continue to take, when they are in the areas of high prevalence. Closing the doors, windows, especially early evening, wearing long sleeves, socks in the evening, dusk to dawn. These are other ways we can keep the mosquitoes away from us, and the parasite therefore cannot reach our bodies. Vaccination. I think I would rather say it's still a long way to go before a vaccine is really approved for the whole of the tropical region or areas with the malaria to use. But in 2021, the WHO recommended this vaccine that is called Mosquirix malaria vaccine for use in high burden African countries really. But as we know, it's not yet in South Sudan, so it might not be a good thing to bank on. But for now, we should just know that in the near future, hopefully, it will become a very common vaccine that people can take. The third thing is to decrease mosquito population. So here, one way is making sure there are no stagnant water are standing around our compounds or our neighborhoods. And we know during rainy season as this, whenever it rains, water can be accumulating. If that water stands there a week plus, that would be enough time for the mosquitoes to breed and grow and multiply in numbers. And so that will help population of mosquitoes to grow, and it will be difficult to really control malaria for that reason, because many vectors around. Okay. Use of insecticides, such as Doom, these ones, they kill, as opposed to mosquito coil, which just repels, for example. So these ones can kill the mosquitoes in the house, and then therefore, if any of them had the parasite, it will not have the chance to transmit it to the human being again. Maybe we will come to that later, the break. Or let me pause there. That's what I prepared for malaria for now. The next thing would be to talk about typhoid. I'm just looking into the chat box and somebody's asking, elaborate on the malaria vaccine, interplay between Duffy blood group and malaria, sicklers and malaria. The malaria vaccine, as I said, WHO are recommended in 2021 for use in highly endemic areas, but it might be issues to do with the cost for countries to afford or other logistical factors that I cannot comment much on. Maybe that's why it has not reached South Sudan. I have not really also gone into the detail of that, and I will not go into details of that in this session. Interplay between Duffy blood and Duffy blood group and malaria. Yes, there's that saying that, for example, blood group O people tend to suffer less of malaria than other blood groups. But in my understanding of this session, I will not go into the details of that because this is a lay person's kind of awareness session that I don't want to take it into more clinical or too much biological or scientific information because it will make understanding difficult, Mr. Wani. Sicklers and malaria, again, there is that basic understanding, science, that people who have sickle cell tend not to suffer a lot from malaria because the way their blood cells, their red cells are structurally sickled, somehow makes it difficult for the parasites to survive, grow, and burst it. So if they are not bursting one cell, that means they will just remain in that cell and they can't multiply and they can't get transmitted and stuff like that. I also kept that detail out of this session for now. Any other question or comment before we start on typhoid? I do know that we have, I have medical personnel here, colleagues. If you want to make inputs, as Beda put it, for maybe the next few minutes, and then we will go on to discuss typhoid. Anybody wants to say something?
Let's discuss typhoid.
Okay. Now that's Dennis, but Batali, you had put up your hand.
Typhoid and we have the...
Yes, thank you, Dr. Leju, for your presentation. Sorry, I joined late. I don't know if you have spoken about the treatment. These days, I'm also seeing there are high chances of recurrences to malaria treatment. I don't know how you can help us on that. Thank you.
Yes, I already have spoken about the treatment. When you say high cases of malaria recurrence, it would be something maybe down to, I would rather put it on dosing or adherence to medication. I cannot say something about resistance. I'm not going to go to resistance. I don't want to say maybe one of the drugs now is having resistance because that is beyond my scope for now. I can't really verify that. But maybe if it is somebody undertreated and then a few days later they get back, or maybe if it was something severe, but somebody managed as uncomplicated malaria, and it could have also resulted to recurrence. But we do know that, of course, we live in the endemic area, so it could be reinfection after just a few days. So those are things I could really say about that. But I will not go beyond things like, into things like maybe resistance of drugs or something, if that is what you are already afraid of, for example. Okay. Right. Let's go on to typhoid.
Yes, hello.
Who is that?
Yeah, this is Kenny John. Before you go to typhoid, I just want you to elaborate more on unspecified malaria. Someone goes for checkup and then the diagnosis, they say unspecified malaria. I just want to know more about that.
Wow, that's a good one. I don't know if I've ever made such a diagnosis, but maybe it is what some people say clinical malaria. As medical personnel, there's the tendency of people saying, let me just treat it as malaria. Even when, for example, the rapid test is negative, a blood slide is negative, somebody has their fevers or headaches and so on, and then we say, let me treat what clinically. Some of us even go and buy the medication over the counter and say we are treating clinical malaria and stuff like that. Maybe if that is what it is, but definitely it is not standard practice. Okay, it is not standard practice. I would rather somebody investigates further what could be the person's symptoms, or rather causing the person's symptoms, or even better, give them a few days to come back and then repeating the tests and stuff like that, than simply just putting someone on anti-malarials. Okay. All right, let's proceed to discuss typhoid, and then maybe the rest of you, if you have comments, you can come in. Typhoid fever most commonly is caused by the bacterium called Salmonella typhi. Salmonella typhi. Also, there's the Salmonella paratyphi, which has subtypes A, B, and C. These others are relatively infrequent causes of typhoid fever, but the most common is the Salmonella typhi. Human beings are the only known host for this bacterium, and a person who is infected with that bacterium can be what we call a case or a carrier. Somebody who is a case is somebody who has the bacterium in the body. It can infect somebody. It will appear in the stool and in the urine, and actually this person shows signs and symptoms of typhoid fever, as opposed to a carrier who may be having temporary or incubatory typhoid, or rather Salmonella typhi in the blood. That, yes, can be excreted from around 6 to 8 weeks of infection, or they can actually revert into what? Chronic carrier status. In this case, they can continue to excrete for about a year, but they will not present with the real typical signs and symptoms at times. They are just carriers of the bacterium, but they can infect people. Okay. The main or the primary source of infection for typhoid is feces and sometimes urine of people who have the parasite, whether they are cases or even carriers. As long as they are now excreting the parasite in the feces or urine, they can infect others. That is the primary source. The secondary one could be contaminated water, food, or fingers or flies. Contaminated water, food from where? Similarly, feces and urine that is carried from maybe outside disposal into water sources, or even from the feces to the food that we are eating, maybe by the flies, or maybe we just grab and eat something that is not clean, which is contaminated with the typhoid, or people who clean themselves or clean others, maybe who have defecated and stuff like that. So the fingers can also be sources of infection. And then flies, of course, carry things here and there as vectors. So we have mainly those different ways we can get this bacterium and can cause for us typhoid fever. Incubation period, again, from the time somebody gets the bacterium to the time signs and symptoms show up, about 2 weeks. Okay, but it depends. It can be maybe just 3 days or even as long as 21 days before the signs and symptoms come up. This really depends so much on how much bacterium is put in the body at the time of infection. Okay, so the lesser the amount of bacterium, the longer the incubation period, and then signs will show up, and the opposite. So the mode of transmission is what is described as fecal-oral or uro-oral, feces to the mouth or urine to the mouth in simple terms. So that is the most common way the bacterium is transmitted. Now, if you hear of things to do with maybe feces, urine, in your mind, you should be thinking about situations where maybe people defecate in the open. So open area defecation or urination, contamination of drinking water supplies. At least these days, especially in Juba now, I see the water that the tankers carry somehow I think has gone through a bit of purification and maybe cleaning processes. Maybe about 10 years or 13, 15 ago, I think these people used to fetch the water directly from the River Nile and supply to your baramil. Okay, so either you had chlorine to put in it, or you had there was one other thing they used to call what, pure water or something. So people would try to clean up their water like that. So contamination of drinking water supplies and food is also a common source. And then vegetables, crops that are grown maybe in sewage water or in areas where sewage water drains into. These crops or vegetables may actually also be dirty enough to carry the Salmonella typhi bacterium. Then of course the low personal hygiene is very helpful. So this is just to describe that. You have the feces and the urine, either from a case or a carrier, and then it is either the water, soil, flies, fingers. Sometimes also foods that are raw or have cooked. At the end of the day, everything just ends in our mouths, especially if we are people who don't have the bacterium, and then we would have contracted it. Signs and symptoms of typhoid tend to change over time. And that's why we have tried to schedule it here by week. So the first week, when the signs show up, second and third week, what are the common things that appear? And in the first week, we have what we call the characteristic step ladder fever, maybe over 4 to 5 days. This characteristic fever or step ladder fever means for the first day, maybe you are feeling a bit of, feverish. The second day, it is increasing. The third day, until by the time it reaches the 5th day, the fever is so high, step ladder. So it's climbing in steps. That's typically a typhoid kind of fever. As you remember, opposed to the malaria one, which we said would even subside and recur after maybe 24 or even 48 hours. This one continuously keeps on going higher and higher, the fever itself. So this can be really helpful for a clinician to understand if the fever that the patient is reporting is malaria, or it could be typhoid. Say maybe somebody reports 3 days of fever, you should know, has it been gradually increasing in the degree Celsius, the temperature itself. Headache, vague abdominal pain, constipation are some other signs and symptoms within the first week. Some people may get weakness, muscle pains, relative decrease in heart rate. This is hard to assess, especially unless somebody is there every day taking their heartbeat. But the weakness, the muscle pains, the client or the patient should be able to report. These are typically things within the first week of onset of symptoms. As nothing is done, by the second week, mild organ enlargement begins to happen in majority of the patients, mostly again, the liver and the spleen. For others, skin rashes, which are described as rose spots, may appear, and then they might also get diarrhea within the second week of symptoms. These rose spots or the skin rashes may depend on the color of the skin. They might be very easy to see if somebody is lighter skinned as opposed to somebody who is darker skinned. Third week, nothing still done, no treatment. Patient appears now in what is described as the typhoid stage, where they have prolonged apathy, they are toxic, they are disoriented, okay? Diarrhea now becomes very apparent. And if this continues like that, untreated, 5 to 10% risk of perforation of the gut, okay? And of course, internal bleeding into the abdomen and all that can happen. So the progressiveness of symptoms for typhoid from medical help is helpful for the medical practitioner to try to understand if indeed it is malaria or typhoid, okay? And of course, history, as we shall also see, is very important in terms of making diagnosis here. So the rose spots may be easy to see here for this person, although the picture is not clearly showing, but we can, patients, fever may be high, somebody having diarrhea, chest congestion, typhoid, meningitis is also another sign, which may now be a complication really of the typhoid. So in the diagnosis, of course, history has to be taken, physical examination has to be done. History, importantly, would be about the feeding style of the person. What do they eat? Where do they get the food? Is it prepared at home? Is it from the restaurant? Or they just eat roadside food? This might be very helpful because the level of contamination might vary from one source to the other. Maybe also the drinking water and stuff like that need to be, to be explored, to be asked about. And then physical examination, of course, for any relevant signs and symptoms, as we have seen in the previous slides. Laboratory-wise, as it appears here, there is one common test, the Widal test, that is done, which is only testing for antibodies to the bacterium, the IgG, IgM antibodies. The problem with that test is that it is unreliable because some of those antibodies are not really specific to Salmonella typhi. Okay, and so even when it is reactive, it might not be very definitive to say, yes, this is typhoid causing these antibodies to go higher. Okay. Also, the other issue about that Widal test is that some antibodies tend to rise later in the illness. Okay, so that means somebody would be actually already in danger of getting the complications. That's when maybe it will show a positive test. So the Widal test is not really very reliable for those reasons. And because of that, the standard way to test or investigate for typhoid is the culture. I know this might not be common everywhere, might not be affordable for most people, but I think in Juba, it is possible to do a culture for blood within the first week, blood culture. So first to second weeks of signs and symptoms or infection can really be, blood culture can be done, and it will show, it will really tell whether typhoid is present or not, whether the Salmonella typhi bacterium is present in the blood or not, because within these 2 weeks, there's a lot of multiplication of the bacterium, and therefore it will be in high population in the blood. By the 3rd week, of course, you expect the body's immunity to respond and try to fight it and maybe even reduce the bacterial load. So also it becomes more excreted. So the bacteria is more excreted in blood. Somebody please mute. Can somebody please mute? Maud Achek, thank you. So in the 3rd week, because the bacteria become so many in the body, also in the GIT, I mean in the digestive system and so on, they get excreted in blood. So a stool culture becomes very helpful. And by the 4th week of infection or signs and symptoms, urine also tends to have this bacteria. So they can still do a urine culture. All these different cultures are the most preferred way to diagnose typhoid and say, yes, this is typhoid and I'm prescribing this kind of medication. If it is not treated and it progresses as we saw, there are complications that can be expected. General complications such as shock could result from, of course, the infection itself can cause the shock. Digestion, or I mean in the digestive system, as I mentioned earlier, there can be damage or perforation of the gut and then therefore bleeding. This is more common really later in the infection by around the 3rd or 4th weeks from infection. In the nervous system, somebody can present with a deranged status, mental status. They may be in coma, or actually they may have meningitis. So when the infection has gone all the way into the brain and the coverings of the brain, they are inflamed and all that. Okay. Other miscellaneous complications could include organ injury that can really go across all many organs, and particularly in sickle cell patients, even bone infection or osteomyelitis may also result. as complications of typhoid. So you see also that it can have very many systemic complications if it is not treated or if it is not diagnosed correctly and therefore not treated correctly. Okay, assuming we are able to diagnose it, the treatment first is oral fluoroquinolones. Common example is ciprofloxacin, and there are many other fluoroquinolones in the market. If that might not be helpful to somebody, there are other options, including chloramphenicol, amoxicillin, ampicillin, and so on. Also, if it is known that maybe the fluoroquinolones already are, I mean, the typhoid has developed, or rather the Salmonella typhi has developed resistance to fluoroquinolones, then other broader spectrum antibiotics like azithromycin and the third generation cephalosporins like ceftriaxone can be helpful. The problem in Juba is that people tend to go for these first. You know, even when they're using Widal test that I have already said is not very reliable, they want to start people on injection either to clear their drugstore or the pharmacy of those ceftriaxone and so on. This is the issue here. And that is what might later actually lead to resistance to these other antibiotics, especially the oral ones. If a patient has chronic carrier state, so the bacterium is in the body and it is just there, they may need a prolonged or 4 weeks treatment with the fluoroquinolone. Okay. For some people, they may have cholecystitis, which is actually gallbladder inflammation. And in some cases, that gallbladder might need to be removed altogether for the chronic carriers. Otherwise, apart from the antibiotics, also patients will need supportive treatment, such as pain or fever medications, adequate hydration, and then nutrition that is appropriate really to help them pick up and maybe overcome the typhoid infection. How we prevent typhoid infection? Control of sanitation is one very important thing. Our source of water, drinking water, we need to drink purified water or at least decontaminated water or chlorinated water, something like that. Okay. Promotion of food hygiene. It's so common with the fruits. Some of the fruits that, especially those that we peel, we think because we are peeling away the covers, we don't need to wash them. Sometimes it's not correct. So the spelling error here is wash fruits. We need to wash all the fruits, whether you are eating them like that or you need to peel them. It's always good practice to wash them. And then, of course, improving basic sanitation, having toilets so that people don't defecate in the open, they don't urinate in the open. And of course, personal hygiene, simple hand washing can really reduce several cases of typhoid as we see in this picture here. Apart from those basic or general measures, immunization or vaccination can be done, mostly for us, people like us who are living in endemic areas as well. Okay. It can also be good for school children who are mostly at risk, and also hospital staff who are also mostly at risk of any form of hospital infections or nosocomial infections. Household members can also be vaccinated, food handlers, particularly in the restaurants. If we had a very strong public health system, they should be doing regular checks at all restaurants. Who is preparing the food and where is their health certificate? What tests did they do and how long did they do it ago? You know, that kind of thing is very, very helpful for the public as a whole. In terms of vaccines, there is the injectable typhoid vaccine and then the oral one, which is taken as a capsule. So the injectable can either be put under the skin, subcutaneous, or into the muscle, which could be either here or in the buttock. Okay. And it can be used for people 2 years and above. So even children of 2 years can receive this, as opposed to the oral one, which is taken as a capsule, of course, by mouth using either water or milk. It's taken 3 doses on the 1st, 3rd, and the 5th days. Within this time, ensure that somebody is not also taking another antibiotic, because the typhoid one or the oral typhoid vaccine is live attenuated vaccine. So the Salmonella typhi is just weakened to be put in the body so that it can trigger the manufacture of body defense against future infection with the bacterium. So if somebody is also adding on other antibiotics, they might completely finish this vaccine, the weakened bacterium, and then it will not give the effect that is required. This one is given for children 6 years and over. I mean, people who are 6 years and over, but it will need a booster dose after 3 years. In summary, for today's presentations, malaria, as I said, is caused by a parasite, Plasmodium. It is not always associated with the typhoid. We need to take note of that really seriously. And the most common practice of double diagnosis, malaria, typhoid, malaria, typhoid, malaria, typhoid, most of it actually, if you do proper investigations, is not correct. Okay, is not correct. A true typhoid infection has a characteristic presentation, as I mentioned. Whoever is a clinician in this call should be able to discern or tell the difference and make the correct diagnosis based on proper history taking, physical examination, and then hopefully doing the best possible test, laboratory test. Okay, as I said, the best test for typhoid is the culture, either blood, stool, or urine, depending on whichever is available, or rather the time of onset of symptoms from infection. The Widal test, as I already said, is not reliable. It will not really be fair. You just screen me with the Widal, and then maybe the IgM is reactive, IgG is negative, and because you found no malaria, and you are just saying, okay, practice, and it's not really very nice. First line treatment for typhoid is oral antibiotics, unless it is really indicated and the severity is well diagnosed clinically. The use of injection, especially ceftriaxone, should be minimized, because we do not want the burden of antibiotic resistance, and really will not be able to manage other bacterial infections in the future. Personal environmental hygiene and can prevent typhoid. Let's practice it, okay? Let's practice it. It begins with us cutting your fingernails, washing your hands every now and then, preparing food in a very clean way. These are things we should always be keen on and actually educate ourselves from home, beginning from home, before we really go outside of the house. Vaccination facilities and cost of vaccine in Juba, I was not able to establish this. I think if you're in Juba or wherever you are, you might want to begin asking questions. Where can you get a vaccine for typhoid? It will be good to take some of it and see. It doesn't mean if you have already been vaccinated, you will not get typhoid again. No, but at least if it gets you, the severity will be minimized, will be less, because your body already has prepared for any such future infections. Thank you for listening. Bida, are you there? Is Bida there? All right, I'm reading in the chat box. I see somebody has already answered some of the questions there. Why removing of gallbladder? Like I mentioned, in some cases, okay, the gallbladder can become so inflamed, so injured, okay, that it becomes a problem itself, right? And therefore, removing it might also help take away some of the burden of the patient, okay? That is in the severe or complicated form of the disease, really. It doesn't mean everybody with it has to get their gallbladder removed. Do we have vaccine for malaria and typhoid currently for adults? The one for typhoid, I have just described them. What I said I don't know about is where can we get it in Juba here. It's a homework for all of us. I tried asking around, I could not get. For malaria, I said that WHO in 2021 had recommended one vaccine for endemic areas, malaria endemic areas. I do not know how far the supplies and the implementation is, but of course it was based on trials, okay, what we call RCT studies. Randomized controlled trials were done in countries that have very high prevalence of malaria, and it was seen to be helpful, and so they recommended in 2021. It's there in Juba, Sherikat near Sudken. David Kwai, would you want to put up your hand and really add to that information you are sharing on the chat box? David Kwai Alier. Is David on call?
Can I say something?
Robert Lubajo?
Yes, sir.
Go ahead.
Okay, my main problem is about the coming to the diagnosis related to the testing. So I'm not still well clear about the culture. Like after the culture, what would be the other things that they can do specifically, especially when the patient has great resistance to this typhoid?
Okay, good. That's a good question.
Yeah.
So in the culture, when a culture is being done, actually, this sample, the blood or the stool or the urine, they just take a sample of it, and there is in the laboratory a special, whatever, if I may term it for the layman to understand, something like food, okay, for the bacterium to grow. So if that blood has the salmonella and it is put inside that food, okay, and given 48 to 72 hours most times, most of the cultures, the bacterium will begin to grow, and it will be seen in the laboratory container where it is being grown that yes, this is the bacterium that has grown here, okay? And also as they do culture, they also are doing another additional thing called sensitivity. So as they are growing that thing, they are putting some of the antibiotics, which are usually used for treating these bacterial infection, around the bacteria. So where the bacteria has grown more, okay, around a certain given antibiotic, it means it is now either resistant to that antibiotic or it is actually not sensitive to that antibiotic. But where the antibiotic is so strong and the bacterium is not able to manage, you will find less of it grows around there. So that is actually culture and sensitivity testing. So two things are achieved there. One is the diagnosis that yes, this blood, stool or urine sample has salmonella in it, but also two, the best treatment that can clear it will also be known, and then they will also indicate that this particular salmonella responded to. By responding to means it was what the growth was minimized by bacteria, by antibiotic A, but antibiotic B was not sensitive. It was not sensitive to antibiotic B. That means if you are the person prescribing, you don't want to give antibiotic B, rather you give antibiotic A, to which the bacterium was sensitive and it did not grow much. So that is how it is done, Mr. Lubajo. Oriem is saying for typhoid fever, you can get at Catherine Medical Center. Thank you for that information. Do you know how much it is, Oriem? You can also add that information here. This session is about educating ourselves, making ourselves aware and spreading the news so that we are all healthy. What type of vaccine is for malaria and which one is for typhoid, and the condition applied. Let me not talk much about malaria vaccine because it's not even in this country. And so let's just know that hopefully in the near future, we will get that vaccine in the country. Otherwise, for now, it's not in South Sudan. Typhoid vaccines, I said there are two. There's injection. There's also one that you take orally. I don't know which one in Catherine Medical Center is available. Maybe you can find that out, Madut. What is the scientific difference between pandemic and epidemic and also endemic? Peter, if you are in the WhatsApp group for personal development training, I think we can continue that discussion in that group. I will answer that. The doctors always saying they don't know what typhoid is and it's not a disease. So could you, oh, typhoid is a disease. I don't know why they are saying that. Okay, almost most of the patients in the refugees are meant for of malaria. All right, thank you, Oriem. So you got your job last year, 3,000 SSP. I don't know how much it is now, if that was last year, but it is worth exploring, ladies and gentlemen. You can walk over to Catherine Medical Center and check it out for yourself. So most of your patients in the camp, in refugees, are treated for malaria. It's possible because like I showed in the map, all of us, even Uganda, South Sudan, most of the tropical African countries are considered endemic. And that is actually now taking me to discussing your question. Endemic means year in, year out, that disease exists there, in simple terms. So since we were born, and probably maybe until we leave this world, malaria has been here, is here. It might still remain here, although we hope it will get eradicated someday, right? So that is what we term as endemic. Pandemic is anything that now cuts across. You remember COVID, when it first started in China and it was still confined within China, people didn't bother about it a lot. When it started crossing borders and went all over the world, now they said, oh, this is now a pandemic. So pandemic has no specific borders restricted to it. A disease is everywhere, okay? Epidemic, you know, epidemic can apply to both even an endemic disease or a pandemic disease. An epidemic is simply a sharp rise in the incidence of a disease. So even malaria that we say is endemic in our countries can also have an epidemic. So an epidemic would be, for example, if a hospital used to treat about 10 cases of malaria every day, every month for the last 5-10 years, 10 cases every month. And now this month of August, for example, they are treating 30 cases. That can be defined as an epidemic. There is a sharp rise in the cases for that particular thing. So that becomes an epidemic. Thank you, Data. I have seen that there are colleagues of mine online. Manny Patrick, are you there? I see your hand is up.
Yes, thank you for the presentation, Dr. Leju. My supplement would be on the malaria treatment that you have elaborated on, especially chemo preventive measures. Yes. Currently, the guidelines, as in Uganda, they are suggesting that if a patient has been managed for severe malaria with all those complications of 8 to 10, when you are considering discharge, mind to do a follow-up, especially patients who had gotten acute kidney injury, who had severe anemia, those one who came with their circulatory collapse, and even those one with the coagulopathies. You do a monthly review, as you also give them the discharge medication on a monthly basis for at least about 3 months to prevent recurrences of the disease, because their clearance by that time it won't be that much. An emphasis is on the vulnerable groups, especially the under 5, the pregnant mothers, the sicklers. They are really mostly targeted, because they found out that the mortality normally after being managed in the hospital, you don't follow them up in the first about 1 to 2 months. Some of them really goes and they pass on just from home. And then concerning the vaccine, I asked you because I also wanted to get more clarification being a senior. Maybe you have gotten some information. But as per last year, I also heard that it will be kind of inaugurated in this year by WHO. So I was inquiring in case of any knowledge that you would share with us. About typhoid, I think it's really becoming a notion that whenever we receive patients from any referring peripheral clinic, they are diagnosed malaria or typhoid. And then these PUD, yet they are, but they just cling to that typhoid and malaria, which is when you do your test and indeed there is nothing related to that, actually you discover other complicated diseases. So I think people should just have family awareness, community awareness on when to seek medical advice and where appropriately. Some clinics have branded their places, they are known, but still there are some errors happening. So I think we should just treat a person as a person, not that everyone who goes there is going to come with malaria, drugs, and so on. So that is a good emphasis. Let's have a community awareness on that. Thank you so much.
Thank you very much, Mr. Wani. Yes, thank you for adding about the updated guidelines in Uganda. I think for South Sudan, the guidelines are still as old as 2019. Please, if somebody in this call is medically practicing and has latest guidelines for South Sudan, later than, or rather more recent than 2019, please try to share with me and let me see what is in there. I did not so much go into it because I think maybe they need editing now or review. So thank you for that addition, Mr. Wani. The issue of malaria and typhoid all the time diagnosed in one person all the time is really becoming an epidemic now, if you like. And I think if I was the patient, I would rather say, please, for now, can I take malaria treatment? And then I'll see after the 3 days. If nothing changes, I'll come back, you know. And as practitioners, we should also be a bit cautious and actually help our patients to understand that we can start by treating malaria first, and then we see. Sometimes the IgG, IgM thing is just reacting for the sake of other reasons, not really because of typhoid. Thank you, Wani. You can lower your hand. Babikir.
Yes,
Babikir,
thank
go
you,
ahead.
Doc, thank you for the well-informative presentation. This is excellent, actually. I just want to comment and contribute to the last point you were talking about. From my professional background, I am a lab tech who actually run a lot of diagnosis. And yes, it is true. Both malaria and typhoid cannot be diagnosed on the same patient with the technique that we're using currently at different clinics. People are using serological just to check the presence of the antibodies, like you said, IgG, IgM, and there is a lot of disease which can actually raise the titration of these antibodies and give you a false positive result, as it is in as it is in typhoid now. Whoever came to clinic and all the Juba City, I think all South Sudan patient whoever went to malaria, the clinician requested the BF and Wheeler test, and both of them came back malaria parasite seen or typhoid reactive, for example. So the technique that which is used for diagnosis, it was actually disqualified by WHO in 2019. I remember they disqualify using this Wheeler test reagent, where the slide test direct recognition test, they disqualified in many countries. So people are supposed to use, like you said, a culture, which is the genuine one and the correct, actually, confirmation for diagnosis of typhoid. But clinically, I have seen because when you get both reactive, you will get, of course, they give you ceftriaxone and anti-malaria, and both of them actually they work. So the patient got improved, and it come to and it has become a norm. Actually, unfortunately, you go to clinic, you came back with a lot of medicine, anti-malaria, and definitely ceftriaxone and so on. So this is actually need a lot of awareness. And actually, I wish if our medical practitioner can understand this very well, so we can not contribute to the resistance which is going on today. Thank you so much.
Thank you, Babikir. Dennis, do you want to say something?
Yes. Okay. Thank you very much, Doctor, for the wonderful presentation. Mine is, I want to start by the issue of the guideline. For South Sudan, we are still using the guideline of 2019. There is no any latest guideline after that. The two previous speakers have talked about, there is a need of much awareness, because for now we are tackling the communicable diseases, but the next problem we are going to tackle is the antibiotic resistance. Because you go to a clinic, they just test there's malaria, there's typhoid, and we know very well this Weedle test. Though they are good, they are not really so much reliable. If we are to check most of the people who are tested for this Weedle test in the clinics, almost 80% are reactive. And this will take us to look at our surrounding, our families. We need to aware them. When someone is also asked, like, you have typhoid, is the patient to decide whether he needs injectable or oral, which is not the case. A healthcare practitioner should know the right of the patient, has to receive the right medication, the right route of administration, all those things. But you find at in our context, in most of our clinics, I'm not against, but most of these small clinics, not the recognized ones, the patient is asked, which one do you need? Do you need the oral or you need the injectables? And the perception we have is that the injectable will treat you quickly than the oral. So people end up going for these these injectables, not knowing that they are going to create this issue of what? Antibiotic resistance in the long run. So it is really going to be a big problem to the whole country, the way I've seen. Otherwise, thank you.
Thank you very much, Dennis. That's very true. Thank you for adding to my voice. And I really think a lot of you in this call are actually people of medical background. Some of you are practicing clinically, others are not. It is our responsibility collectively to help our community to understand, our communities in different places to understand that, in fact, coming to see a doctor and going home without even paracetamol is still helpful. It's still good. It is very difficult for somebody to come to a doctor and the doctor screens everything, is not there, and says, you know what, just go back, take a rest, or maybe, do some exercise, come back after this number of days. People don't feel good. They will say, actually, you're a bad doctor or a poor doctor, or you don't know what you're supposed to do, and they will go to another clinic. So it's our responsibility to also health educate our people, our patients, to understand that recovering from any situation or any bad health does not necessarily always need a drug, or does not always need an injection, or does not always need an antibiotic for that matter. It could be paracetamol alone, just for a headache that is not pinpoint for now. So it could be other things like stress, other things that might not need any other serious medication. So I agree with all of you. We have all the responsibility to do that. Whoever is practicing clinically currently, of course, you really need to update yourself, look for the latest guidelines and practice according to what is the latest recommendation. Because in this world of science and medicine particularly, there's a lot that keeps changing. A lot of studies go on, and the findings are being verified and included in guidelines, in recommendations, and all this. So it is our responsibility to practice that in a very, very modern way. I think if there's nothing much, I thank you all for your attendance and participation. Slides will be shared online, maybe by Monday or Tuesday. Bida or Emmanuel Karaba, are you there?
Yes, I'm here.
Yeah. So I think from my side, it's thank you to everybody, and I'd like to hand over to you, Emmanuel.